You're in the middle of a busy clinic day. Your Achilles patient looks at you and says, honestly, it felt better before we started progressing it. And then your shoulder patient lifts overhead, but only if you're right there breathing down their neck, micromanaging every rep. And between that, you got to keep up with the notes, admin, supervision, and still think clinically. On paper, everything is correct. The plan makes sense. The progression is logical. The exercise prescription ticks all the boxes. But in real life, there's a gap that you can feel straight away. That gap between what looks good in the room and what actually works for the patient when they go home. Major point number 1, when structure replaces clinical thinking. You're taught that evidence-based protocols are your safety net. Match the diagnosis to a loading plan, progress it in a structured way, and in theory, outcomes should follow a nice, predictable line. But in real practice, those same protocols can stop being a guide and start being a hiding space. Not because they're wrong, but because they're safe. They give you something defensible to write in your notes. It's easier to write progressed 3 sets of 10 at 5 kilograms than it is to describe what you actually saw. And what you saw might be something like, patient reports no change in TheraBand work, but still avoids lifting a laundry basket at home. Or that quiet moment when you can tell that they don't really trust using their arm. That stuff, the behavior, the hesitation, that lack of buy-in. This is the messy clinical truth that no one teaches you how to capture. I'll be honest, sometimes the protocol isn't wrong at all. I just didn't want to step outside on a busy day and do the harder work of thinking through what was really going on. That's where people get caught. When the day gets slammed, you stop watching the patient and start executing the plan on autopilot. Sets, reps, progression rules, they become the focus, not whether the person in front of you is actually changing in a way that survives outside the clinic. And when progress stalls, the safest option is to stay inside the protocol. At least you can justify it. So instead of questioning it, you double down because the protocol feels like wrapping yourself in a nice, warm, familiar burrito. Major point number 2, looks fine in the clinic, breaks at home. In training, you're taught a clean assumption. If the movement improves in a clinic, it should carry over in real life. Clean movement, better loading tolerance, better function. Nice simple line, nice and tidy. Then you start working and you realize that line bends. It bends a lot. I see it in 3 ways all the time. A shoulder patient who looks great in front of you, smooth overhead reach, good control, everything coordinated, and then they go home and stop using the arm in the same way because it feels tight or unsafe without you there. The Achilles patient who loads perfectly in session, the numbers look good, the progression is on track, then a normal week hits them, poor sleep, stress, fatigue, life stuff. Everything regresses, not because the tendon failed, but because the system around it changed. And then there's the nursing home resident. They pass all the balance tests in a bright, controlled environment and still fall at 2 a.m. in the dark room, half awake, wearing oversized slide slippers that should never have been invented. Same pattern, different conditions, different people. Here's the bit that actually sucks. In clinic, you're not training movement in life, you're training movement under supervision, ideal conditions, real-time cues, reassurance, and correction. So the question becomes less, did it improve here, or more, what did we actually train, and what disappears the moment I'm not in the room? Sometimes the better it looks in the clinic, the more confident you get and the easier it is to miss what's not surviving elsewhere. Major point number 3, it works here, but not in real life. Experienced clinicians don't have better protocols. They just change what happens next the moment something doesn't carry over. So when the patient says it felt better before we progressed, they don't treat it like a vague feedback, they treat it as data. They pause the progression, they strip things back, change how the movement is being loaded or experienced, even if on paper everything still looks correct. Stop treating the progression as automatic and stop letting the plan run the show. Real world carryover becomes the actual test. Over time, that changes how you make decisions. Less that the numbers are better, so we progressed it. More, this hasn't survived outside the room, so we didn't move on. It's a subtle shift, but it's a big one. You stop progressing the exercises and start interrogating whether the movement actually exists anywhere beyond supervision. Bonus point. The more rehab just hides the problem. One thing you learn over time is that more exercises don't mean better outcomes. Often it's the opposite. A long list of exercises just makes it harder to see what's working and what's noise. So instead of giving 5 or 6 home exercises, scale it back, 1 or 2, not because you're lazy, but because you're trying to isolate the truth. Can they carry groceries without guarding? Can they get off the floor without hesitation? Can they load the limb when nobody's really cueing every rep? That's what matters more than perfect TheraBand form in a controlled setting. We've talked about this before. Active beats passive, keep it functional, but the active part only matters if it survives outside of your supervision. Otherwise, it's just rehearsal. Too much rehab creates noise. A lot of things that look productive don't improve the patient's life. That's physio theater. So the shift is simple, less complexity, more exposure to real tasks like waiter carries instead of cone reaches, countertop push-ups instead of endless TheraBand work, mini squats instead of quad sets and straight leg raises. Not because those exercises are wrong, but because the context decides whether they matter. Clinical exercises are the rehearsal, life is the test. And the job isn't to build the most impressive program, it's to strip things back until the real limitation is impossible to hide and then deal with that directly. Some of my worst clinical decisions weren't the aggressive progressions, they were the zombie weeks, the weeks where I kept progressing even though nothing was actually improving for the patient at home. The numbers looked fine, the exercises looked good, but the reassessments weren't moving the way that it mattered. So I didn't want to admit it, that I was stuck, so I stayed inside the plan longer than I should have. Every physio hits that moment eventually. You realize that the patient doesn't care whether the program looks good or not. They care about their life getting easier. That's our physio job. Not making things look good in the room, but making sure it holds up when they walk out of it. And if it doesn't, the answer isn't more complexity, it's asking harder questions. Did this actually transfer or does it just look good on paper? And honestly, it took me far too many years to realize I'd basically been running a small community theater troupe of beautifully performed exercises that meant nothing once the curtain closed. It took me long enough to stop directing and start treating. That's physio. Thanks for watching. My 2 books are now available at Amazon. What They Don't Teach You About Documentation in Physiotherapy School, a short how-to manual for successful daily note templates, and From Injury to Recovery Through Exercise, simple functional exercise progressions for physiotherapists to restore lifting, standing, walking. Thank you for your support. Buckle up, because this video is a wild ride, and by subscribing, you'll be part of a community that values growth and knowledge. Thank you.